and welcome to Health Affairs This Week. I'm your host, Jeff Byers. We are recording on January 7th, 2026. That's right, we are back after a short break. As a heads up, our sister podcast, Health Podyssey, has joined the video podcasting world on YouTube. It's an experiment. Let us know what you think. This show is not on there yet, but let us know what you think. And if you like it, and maybe we will do a video at a later date. I can confirm that I'm looking pretty good right now, but you'll have to take my word for it. Also, for Health Affairs Insider, we have an event on January 21st with Joey Mattingly on the latest drug policies. Check that out. And today on the program to discuss the recently released National Health Expenditures data on 2024 is also someone looking good, Michael Chernew. Michael, welcome to the program.
Jeff, thanks for the compliment. It is always wonderful to be here. This is such an important topic, and this year I think it's gotten a lot of particular attention. So I'm thrilled to talk to you about this article.
Yeah, so you wrote a piece in Forefront about your reaction to the data, and we will talk about that a little bit more. And I also want to direct listeners to the show notes where we can link to that. But in general, the top line for the CMS data is that national health spending grew 7.2% in 2024, wherein utilization remained elevated. So this compares to 2023, where the growth was about 7.5% increase. What jumps out to you with this number, and how can you contextualize it for people not steeped in actuarial spreadsheets?
Yeah, so those are the right numbers, and I appreciate you mentioning them. I don't think listeners need to join to understand that the top line is basically, we just can't afford this trend in spending growth. And you can contextualize it in a bunch of different ways. Inflation is about 4 or 5 percentage points below that rate of growth. Mid-twos, for example. GDP growth, which is commonly used, is about 2 percentage points below that top line growth. There's basically no benchmark that you could think of that makes us think, boy, we can really afford this 7.2% growth. The one that's commonly used is the share of GDP devoted to healthcare. That rose from about 7.7% up to 18% in 2024. As an aside, Health Affairs published an article of projections earlier in the year. It's projected to rise to 20% in 2033. And so this article essentially puts to numbers the basic sense that we are having a harder and harder time affording the healthcare spending that we're experiencing in this country.
Yeah, and we did a podcast together, you and I, on the projections back in June, I think. So if anyone wants to check out what we talked about then, check out that episode. But, you know, when you talk about, like, we're not able to afford our healthcare bill, like, in some ways, what does that actually mean when it comes to just like what a consumer or a lay person might think about that? Like in your article, you write it's unstable. Okay, what does that mean? The numbers keep going up.
Yeah, so a few things. In a literal sense, we can afford it, right? We're spending 18% of our income on healthcare. That is not 100% of our income. So in that sense, we can afford it. I think what it means is that the pressures that we face to finance that, the tax pressures, the wage pressures, are such that we increasingly balk at paying those prices, or paying that spending. It's actually, as we'll talk about in a minute, much more than prices. It's really a lot of utilization. I think the one thing that's important to remember in a lot of the related policy debates is that much of the policy discussion is around who pays. So can we shift it from individuals to the government? And I think the thing that I'd like to emphasize is that we are not going to solve the aggregate problem by just shifting who pays. One way or another, all of the money comes from collectively all of us. It matters if it's taxpayers or individuals or people who use care versus people that don't use care. All of that matters. But at the end of the day, when healthcare spending rises at a rate of 7.2%, but our income rises at a rate of, take the numbers there, 5.3%, that we feel that the sacrifices that we have to make in order to consume healthcare are bigger and bigger. I think one of the things to note is that the national health accounts are designed to quantify how much we spend and on what services and by which sectors. It's not designed to assess the value of that spending. And I think underlying the statement that this is not affordable is an implicit statement that we don't think we're getting enough value for what we're spending. And I think that's where there's underlying a lot of attention needs to be paid.
Yeah. So your forefront article was pulled no punches, I think. So again, we'll talk a little bit more about like potential solutions and infrastructure. When we go back to affordability, that was one of the major trends and talking points in 2025 is affordability. What can Americans afford? Grocery bills are going up, et cetera. Inflation, technically slowed down from 2023 and 2024. Currently, 2025 inflation's rate looks to be less than those 2 years, but there's a really big asterisk on that full year data since due to the government shutdown. And when we look at that lens of expenditures and affordability, you talked about sacrifices to be made. In that lens of affordability, what kind of sacrifices are being made, and like what can we afford? I don't know.
Yeah. So essentially, as healthcare spending rises, and we should emphasize, and this comes out in the article, this is really driven by utilization in varying forms, utilization and mix. And what we're giving up collectively is either the country goes more in debt, taxes will have to rise, workers get lower wages, or employers require people to pay more out of pocket so they can't buy as much other stuff. And a lot of that's been driven by, particularly in 2024, by what is called utilization and intensity of that utilization. So there's some high profile things that contribute, but they're not certainly the only things, but there's more spending on going to the hospital, more spending on going to the doctor, more spending on retail drugs. Certain specific types of drugs have gotten a lot of attention, these diabetes drugs, GLP-1s. And the core question is, some of those things, I think, provide a lot of value. The GLP-1 drugs, for example, not only are considered clinically very important for a large number of people, they also may lower spending elsewhere, at least down the road. But some of those things may not be adding value, like the article mentioned skin substitutes. And although skin substitutes may add value in particular cases, I think there's a general sense that the utilization of those very expensive products exceeded what was appropriate. And so I think understanding when the drivers of spending are giving us things that we want to afford and we're willing to forego some wages or pay higher taxes or whatever it happens to be is important. And understanding when the drivers of spending are not doing that is also important, because that area of sort of low value spending is where we're going to have to focus our attention.
Yeah, in your forefront article, I think, I'm not putting words in your mouth, but to me, it looks like you're making a case for some potential infrastructure changes down the line and like what could be masked in the actual data when it comes to prices versus utilization. And I think one of the things I wanted to have you touch on here is talking about moving beyond antitrust and private equity when it comes from an infrastructure note. So what can you tell us about that? How might the prices might be masking some of those trends?
Pricing masking stuff aside, I think the core issue is that the healthcare infrastructure, sort of the hospitals, freestanding centers, a lot of integration that's going on. So big healthcare systems are building out new outpatient departments, building out new infusion centers, building out new ambulatory care centers. Some of that stuff is cost saving. It's cheaper to get some surgery on an outpatient basis than an inpatient basis. And I think over time we saw savings in spending because of these type of shifts. But we have to worry that increasingly those types of changes are causing prices to go up. We pay more for offices if it's a hospital outpatient department as opposed to an office or a traditional physician office, and that volume is getting increased because of just the expansion of the underlying infrastructure, or that patients are moving. Volume is shifting systematically to higher priced places, either because of acquisition, renovation of those places, stuff like that. And so what is clear is if we're getting the same stuff, we're just paying more for it, we're not really getting a lot of extra value. And so that's not necessarily an increase in price per se. Any given physician or any given hospital system might be charging a somewhat similar price or a mildly higher price, but the shift in volume towards higher price settings or higher price providers within settings causes spending to rise. And I don't think we know enough about that. You mentioned acquisitions matter, private equity matters, that's important, but there's a lot going on even beyond just those headline drivers.
I thought it was interesting how you noted the impact of the evolving infrastructure, to quote you, and changing patient flows extend well beyond the issues of antitrust and private equity remains poorly understood. I just thought that was an interesting note to we focus a lot on pricing and the data, where there's also a lot other macro trends going on below all this.
It's hard. It's hard on a podcast when you're asked about the things for which the jump off sentence starts. It's poorly understood. So our listeners, I would just emphasize it's poorly understood. People can write in. Here's what you should have understood. The other thing that I wrote about, which relates to this, is there's a lot of stuff going on in coding where we're just the underlying guts of the system relies on a bunch of codes for different types of services. And if we code the same thing differently, which is happening, we end up spending more but not getting any more. And so those things, coding, some of the infrastructure changes and patient flow changes, I mentioned in the piece, AI type things, there's stuff that's going on which may or may not be adding value. And the national health accounts aren't designed to identify those types of things. Certainly what one would take away from this article is we need to redouble our efforts to understand the underlying clinical drivers and the pricing drivers and the market drivers, because we certainly need to find a way to slow spending down below 7 point whatever percent, because the reactions of payers to that higher bill are going to be things that no one is going to particularly like.
So, Michael Chernew, it wouldn't be a podcast in 2026 if we didn't talk about AI. You bring up AI in the article about how it could affect healthcare prices, but explain to the listener what you think about that.
So AI,
I don't want to bastardize your own words.
You know what? You could probably do a better job, but I'm going to take a stab at it. We just live in an era where AI is transforming so many aspects of our lives, and healthcare is no exception. I think it's useful in healthcare to make a distinction between two broad uses of AI, maybe three, we'll see. One is there's a bunch of administrative uses of AI, both good and bad. On the good side, we can do a lot of things cheaper. We might not need the same amount of labor to do certain underlying administrative functions. I think there's great potential for AI to make the healthcare system administratively more efficient. On the downside, AI, I mentioned before the issue of coding. AI may enable folks, providers, to increase the intensity of their coding, which will raise spending. Of course, payers will be using AI to try and push back against that. So there's going to be sort of some version of technology war related to the coding of a whole bunch of things, and AI will be a weapon on both sides of that activity. But all of that's sort of on the administrative role of AI. It remains to be seen net how much money it saves or doesn't save. But certainly it has a ton of potential if we can harness it well. And then the second main area to think about AI is there's huge advances in what AI can do clinically. And when you see what it can do, say helping diagnoses, for example, so you have an image, you send the image to the AI can read it and really help physicians diagnose whether somebody needs or doesn't need a heart procedure or some other thing like that. And if you listen to the narrative around AI, this is just efficiency waiting to happen. We're at the cusp of a technology-induced efficiency bump, which will really help us get out of the spending conundrum we've been talking about. I'm a little less optimistic that will happen. I won't say it wouldn't happen, but you have to think through the number of ways in which AI might in fact raise spending. So for example, if you reduce the number of people getting heart procedures, that would seem like you're going to save a lot of money. That might be true. But maybe all the people that would have been doing the heart procedures, the physicians and the hospitals doing the heart procedures on the existing set of patients, now that they aren't doing as many, they'll bring other patients into the system, what we call backfill, various types of services. Or to use some of the AI, you have to do certain types of diagnostic tests that the AI then reads the diagnostic tests. So maybe what happens is you spend a lot more on the diagnoses because you're doing a lot more, say, CT scans that the AI can ultimately help you interpret. So, and then of course there's the underlying cost of the AI and how you end up pricing the AI. I think there's a long history of medical technologies which have been sold as cost savings, which ultimately have ended up not being cost savings. In fact, to tie this back to the article, spending went up by 7.2%. I'm not sure how much AI reduced that, but boy, that 7.2% is not a sustainable number. So we're going to have to see, and I think we will know in the coming years, the role that AI is playing. But for example, what I'm seeing in 2025 does not let me think that we have at least harnessed AI in a way that allows us to keep that top line number down. We may have increased the value. We may be on the cusp of doing better, but we are certainly not at a place where we have solved our problems via AI. And I worry that if we put all of our eggs in sort of the AI will solve the problem basket, we will ignore some of the policy activities we need to do in order to actually get us to a sustainable fiscal footing.
Yeah, but it's possible our stocks will go up.
It is possible. In fact, I should say the stocks will go up if AI, is profitable, and AI being profitable means someone's spending more money.
Yeah, and I'm a little skeptical about implementation for some of these new technologies, but
we are on the same page. But I think there will be great returns for the people that figure out how to do this well. And there's a lot of people, as you mentioned, a lot of money going into the system to try and figure out how to do this well. Hopefully, we'll come back in a year or two and we'll be celebrating the great success of this transformation, but I don't know that that's a foregone conclusion.
Yeah, time will tell. So we're about to wrap up our conversation today, but I wanted to note from the data, personal healthcare spending averaged around 8.9% this year. So that shows about 15,000 per person in 2024. When you look at the affordability perspective, what can we expect, or is there anything we should expect in next year's data trend wise when we look at the?
I think it's going to be, again, next year in this context is actually 2025. We're talking about 2024. So next year's podcast is going to be when we get the official data for what happened in 2025. And everything that I'm hearing about what we're experiencing in 2025, we have experienced in 2025, is not incredibly optimistic. Certainly, if you look at what's happening in the private employer space, you mentioned personal health expenditures, but some of that is commercial and some of that's government. But on the private sector side, premium increases have been really dramatic across the board. You've seen big increases on the exchanges. You've seen big increases in the commercial market. Here in Massachusetts, we're facing 10% premium increases, give or take. There's a wide range in what that number would be, but I don't see the 2025 data changing the tone of this discussion. I don't see us coming back in 2026 and saying, boy, we were really worried about what was happening in 2024, but 2025 really showed that that was just a blip. I see this period of cost inflation rising at least through 2025, and frankly, I expect it still to be somewhat elevated in 2026. We'll see how that ultimately plays out. And what that means is, for context, that employers are going to be trying to find ways to spend less money. So maybe shifting more people into, say, high deductible plans, narrowing networks, for example. We didn't mention, but I should emphasize, this is in the article, that this is not insurers' profits going up. It's not, in aggregate, the price growth is relatively small. In aggregate, the insurer profit growth is lower than it has otherwise been. That this is underlying utilization of healthcare services. And we need to find a way to manage that better. And so that may end up being narrower networks, people paying more out of pocket, which I think has a lot of problems, but you may see much more people paying things out of pocket, people being asked more to contribute to participate in insurance, which will lead some people to potentially drop insurance. There was a slight decline in insurance rates in this article. But I think we're going to see the pressure. We talked at the beginning about the lack of affordability. What that really means is the behaviors that people take when faced with the premium costs are behaviors that, from a policy perspective, we worry about. They're not using care that they should. They're not buying coverage. They have to cut back on consumption of other types of services, a whole bunch of things like that. And so this is going to end up being a very important policy topic because a lot of the frustration with the American healthcare system bubbles up into the policy arena.
So last question, in your article, in the Forefront article, you talk about a couple different options to potentially reduce spending. If you could touch on the one that you are most bullish on.
For people listening and who don't have time to read, there's 4 that I mentioned. One is reducing low-value care. I think that's the key. But as I note, the devil's in the details. I'm always bullish on improving alternative payment models. I think a lot of the way we're going to have to manage this is how we pay. one thing I'm less bullish on that I mentioned is improving market mechanisms. I should say I am not anti-improving market mechanisms. I'm very pro-improving market mechanisms. I just think that doing so is hard, and the success of that will take a long time, and our past efforts haven't been that successful. And then the last one, which I won't dwell on, I won't say I'm particularly optimistic about just because it's hard to do, is just focusing to imposing regulations to identify the areas where markets fail. So that might include some price regulation in a range of ways. I'm a big fan of standardization in a lot of situations. If I had to pick one, it's probably the alternative payment models. Just because I think we can do that. We just have to improve where they are. And I very much like the focus on reducing low value care and becoming more efficient. I see the alternative payment models as one mechanism to do that. So that's what I think we need to do. And the question is sort of how well we can do it in this complicated world.
Yeah, that is the question. The main question.
Yes. And even who the we is, right? Like you have these on these podcasts, you're like, we need to do this as if we're all on the same page. I think part of the problem is there's so many voices, so many actors, so many people with different views. It's hard to all get behind a single effort. But I think certainly payment reform in Medicare and other places continues to be central if we can design it well.
With that, Michael Chernew, I think you, me, and producer Shannon may have figured out the whole healthcare system here on this podcast today. Hope listeners enjoyed this episode. Thank you again for joining us today, Michael. If you, the listener, enjoyed this episode, please send it to the 2026 Optimist in your life, and we will see you next week.
Jeff, thank you.